Just a few weeks ago, the FDA changed their position about hormone replacement therapy for women. For more than 20 years, hormone replacement therapy was considered risky for their cardiovascular health and potentially causing breast cancer. And now the FDA changed their mind. Is it another sudden, unexpected, weird reaction triggered by the Trump administration? Can we trust them? We have to look at the facts. Hi, I'm Manfred Stapff, the host of the Real World Evidence Perspective, which brings you truth, data, and candid context. For this topic, I need a little bit of a disclaimer. The views and opinions in this podcast are my own and are provided for informational purposes only. No part of this podcast or any related material is intended to be a substitute for professional medical advice and diagnosis. Treatment decisions should always be based on current science and on an individual risk-benefit discussion between healthcare provider and patient. So first we have to understand what your hormone replacement therapy actually is, why it may help women in the age of around 50 and older, and how it can significantly relieve symptoms of their menopause. And then, of course, it's very important to understand why hormone replacement therapy, HRT, was considered so risky more than 20 years ago. How did one interpret the study results at that time, and why do we now see it differently? What were they thinking then, and what are we thinking now? Hormones are a very complicated and very important system to regulate functions in our body. And whenever, because of a certain reason, for example an inflammation, a hormone system doesn't work well, we correct it. We replace these hormones, usually by a therapy and giving the missing hormone. So if our thyroid, for example, has a low function, hypothyroidism, we give thyroid hormones, T3, T4, thyroxine. If our suprarenal glands do not produce enough steroids, this was, for example, the case President John F. Kennedy had Addison's disease, then we give steroids, or if necessary, we give testosterone. If our pancreatic glands do not produce enough insulin, we get diabetes, so we give insulin, in this case diabetes type 1. But if the women's ovaries do not produce enough estrogen or progesterone, we take it as a normal symptom of aging. If you Google the word menopause, you still find the explanation that it is a natural process happening as women age. Okay, it's natural, but it comes with a lot of symptoms and also long-term health risks, which can often easily be addressed by reinstating the hormonal balance. So, as the name suggests, hormone replacement therapy is replacing low or insufficient hormone levels. In the case of menopause, this is estrogen through a dermal patch, oral or through a vaginal cream. And usually if the woman does not undergo a hysterectomy, then also progesterone. These products carry a so-called black label. What is this? This is a serious warning mandated by the FDA. And this warning is one of the reasons why physicians often hesitate to prescribe hormone replacement therapy, although it could help many women to relieve their symptoms of menopause. A black box label is always a trigger for doctors to feel legally culpable and for lawyers to sue if something goes wrong. So where does this opinion come from? In the 1990s, one did not know a lot about specific patterns of heart disease, especially in women, because most of the studies were conducted in men. So therefore, the NIH created the so-called Women's Health Initiative to evaluate the cardiovascular benefits of hormone replacement therapy for women after menopause. We need to keep in mind that this study was intended to evaluate potential cardiovascular benefits in women approximately 10 years after the menopause. Their mean age in this study was 63. The study ran from 1993 to 1998 and enrolled approximately 17,000 women. The mean follow-up time was 5.2 years, so the results were published in the year 2002. In the year 2002, the results became available and have influenced the FDA's and physicians' opinion about hormone replacement for the next 20 years. So what were the results? I'm using the numbers as the FDA uses them in one of the prescribing informations for these products. And this is calculated for women, for 10,000 women per year. So one sees that the stroke risk under hormone replacement therapy was 33 women per 10,000 women, while it was under placebo only 25. This is a difference of 8 women in 10,000 women. For myocardial infarction, coronary heart disease, it was 41 versus 34, so that's a difference of 7 women in 10,000 women experienced a heart attack. For cancer, women's cancer, breast cancer, endometrial cancer, cervical cancer, it was 49 versus 41, so 8 women in 10,000 women experienced cancer during the hormone replacement therapy. So these are a lot of numbers, and it shows a tendency for a higher risk in 10,000 women. As I said, 7 or 8 women more per 10,000 per year. Due to the high number in this study, this partially became statistically significant. One has to know that statistical significance is just a mathematical value which confirms the validity of the study in terms of variation, standard variation, unexact measurements. It's a pure mathematical number, how reliable the data are. However, whether it's clinically meaningful, it has to be looked at for clinically relevance. And one way is to look at these numbers, 7, 8 or so women per 10,000 women. Another way is using the number needed to harm. If it's a negative effect, a bad effect, a side effect, one calls it a number needed to harm. And here the numbers are that, for example, among 1,250 women, 1 woman gets a stroke related to the hormone replacement therapy. For heart attack, it was about 1,400. For other cancers, it was again about 1,200 women needed until 1 woman developed a cancer because of the hormone replacement therapy. I like this number needed to harm as an expression of clinically relevance. You may see that in other episodes of my podcasts. If we combine that or compare that with the risk of smoking, we see that per year the risk for lung cancer due to smoking is 15 times more than a non-smoker. This would be a number needed to harm of 714, which means per year. So usually you don't smoke only 1 year. So if it's 10 years, it's already down to 71. If you smoke 20 years, it's down to 23, meaning that 1 in 23 women get a lung cancer, not women only, 1 in 23 smokers get a lung cancer because they are smoke, in addition to the natural, which is relatively low, the natural risk of developing lung cancer. After these study results became public and were widely distributed by the media, the number of women receiving hormone replacement therapy declined dramatically. Hormone replacement therapy was basically demonized. Bad thing, bad thing. And if one estimates that in the United States, approximately 40 million women per year are in the menopause transition age, and if one thinks that about 60 to 80% of them have symptoms like hot flushes, depression, night sweating, and this could be alleviated or healed by hormone replacement therapy, then one can calculate that every year about 10 to 20 million women were denied a helpful therapy. Not mentioning the secondary effects, the burden on marriages, on families, the mood swings, the problems with effectively performing their jobs, and other symptoms which appear with menopause. But there are benefits, obviously. So let's look at that. The symptoms and long-term effects of menopause can be addressed by hormone replacement therapy. Even the good old Women's Health Initiative study found a benefit, a protection from osteoporotic fractures. There were 152 versus 199 osteoporotic fractures per 10,000 women per year, which is 48 per 10,000 women were protected from an osteoporotic fracture by hormone replacement therapy. One also has to know that osteoporotic fractures, with all the combinations which can come, they are bedridden, maybe thrombosis, pulmonal embolism, all these complications. Because of these complications, osteoporotic fractures have a similar mortality risk as breast cancer. Also, colon cancer was slightly less observed with hormone replacement therapy than in the placebo group. The number needed to treat, now we call it number needed to treat because it's something beneficial, was very high, so I would not take this extremely serious. It does not primarily prevent colon cancer, but it does not cause colon cancer. Another thing is new diabetes. Hormone replacement therapy, it was shown in another study, can definitely protect from a new onset of diabetes. Here the number needed to treat is 143, relatively high, but it is a clearly protective effect. Now let's talk about the symptoms. They are the most important ones. Not only long-term benefits, but also short-term symptoms. Another study showed clear benefit in the treatment of hot flushes. Another study showed clear benefits in treating a depression. So hot flushes, depression were solved in 60 to 70% by hormone replacement therapy and only 25% by placebo. This translates in the number needed to treat of 2. So now you realize the lower the number needed to treat is, better the clinical significant. The number needed to treat means every second woman here, number needed to treat 2. Every second woman clearly benefited from hormone replacement therapy in terms of hot flushes or depression. So these were a lot of numbers, a lot of statistics, a bit complicated obviously, so let us summarize. First, we have to evaluate whether this 20-year-old study is even the appropriate basis to address the question we have today. Meaning, is hormone replacement therapy more beneficial or more risky in women around or shortly after menopause? Here we have to look at the specific features of this study 20 years ago and what are we asking today. So the intention of this study 25 years ago was, do hormones have a cardiovascular benefit? Today we are asking, does hormone replacement therapy relieve symptoms of menopause? What was the age range of the women in the old 25-year-old studies? There were a mean of 63 years, which is on average about 10 years after menopause. Today we are asking, and we are using this therapy within 10 years, within the menopause, in the age of late 40s, early 50s. What was the therapy given at that time? It was an oral compound. Today we have mainly transdermal patches. What was the estrogen used at that time? At that time one used equine estrogen from horses. Nice. Today one uses bioidentical synthetic estrogen. And then look at the dose. At that time in the study dose was 0.625 milligram. Today, usually one uses much lower doses, up to 0.1 milligram. So there are significant differences. And this study is totally outdated for today's hormone replacement therapy question. And they asked the wrong question and the wrong population with the wrong product. So this study is totally outdated today. It showed that the risk of developing breast cancer or developing a cardiovascular disease, for example heart attack, is minimal. It was less than 1 in 1,000. But the benefits absolutely outweigh the risk. The benefits, hot flushes, depression, night sweating, are clear. Every second woman benefits from hormone replacement therapy. So if your intention is to alleviate, relieve symptoms of menopause within 10 years of menopause, so in the age of the late 40s and early mid-50s, yes, hormone replacement therapy has an absolutely positive benefit-risk profile. In case your intention is cardio prevention, avoiding heart attack, in an elderly woman 10 years after menopause, then you better don't do it with hormone replacement therapy. There are better ways. You look at your cholesterol, you perhaps take a statin or ezetimibe or another cholesterol lowering drug. You of course don't smoke. You lose weight, you be physically active, you control your blood pressure. The standard methods to keep your heart healthy and avoid heart attack and stroke. Obviously, such treatment decisions should always be made individually between the patient and the healthcare provider, your physician, your nurse practitioner, after individual risk-benefit evaluation using the best available scientific and fact-based information. That's how it should be anyway in healthcare. Healthcare decisions should be made individually based on fact-based scientific information and only advised by government officials, not mandated by the government. This is how one should approach complicated topics anyway, looking behind the facts and data rather than immediately following some ideologic or political statements. You can read it in my newest book, Real-World Evidence Unveiled, Navigating the Maze of Misinformation. It's available on Amazon, ebook, paperback, hardcover. I hope this journey through a lot of data and a lot of facts allowed you to understand the overall context and allows you to make your own decision together with your healthcare provider. I also hope that it became clear to you that the change in direction recently made by the FDA by removing this black box in this case is not an unpredictable, difficult to understand, spontaneous action of the Trump administration. No, it is scientifically motivated, fact-based, and in this case it's not politicized. Another issue is, why did it take so long? 25 years. Why did it need active and committed women to fight so long to get this issue solved? If it was about health problems in men, if men had to endure all these symptoms, perhaps science would have moved forward a little bit faster. Thank you for watching the real-world evidence perspective, which brings you truth, data, and candid context. Don't forget to like, forward, comment, or subscribe, whatever you feel appropriate. And don't forget to order my book on Amazon. Thank you very much.